Welcome, everybody. I'm Mike Ciarametaro, Vice President of Research with the National Pharmaceutical Council, and I will be your moderator today. I am pleased to be here today to discuss the pertinent topic of transformative therapies and their implications for the U.S. healthcare system. In the last 5 years, the U.S. has seen several transformative therapies enter the market, including hepatitis C and several gene therapies. The number of these types of therapies is expected to grow significantly over the next 5 years. As illustrated in the cartoon, these therapies have the potential to fundamentally alter the way that we treat patients. No longer will patients be required to endure a lifetime of treatment. Rather, these therapies will often be a single treatment that spans a day to several months. However, this paradigm shift is not without its challenges. Changing the way that we care for patients in a significant way requires that we step back and assess whether current payment models need to evolve to support these changes in care. The goal of today's webinar is to better characterize these payment challenges and begin to discuss potential ways forward. Today's webinar will include 4 thought leaders. Up first is Genia Long, who is a senior advisor with the Analysis Group. She will present some research that explores the potential payment challenges for these therapies and how they may differ across diseases. Following her presentation, our panel of experts, including Dr. Michael Sherman, Jeff Myers, and Timothy Brent, will present their perspectives on payment challenges and solutions for these therapies. Dr. Michael Sherman, who is the Chief Medical Officer and Senior Vice President of Health Services at Harvard Pilgrim Health, will provide the commercial payer perspective. Next, we have Jeff Myers, who is President and CEO of the Medicaid Health Plans of America. Mr. Myers will provide the managed Medicaid perspective. Our third panelist is Timothy Brent, who is the Senior Director of Business Development with the National Hemophilia Foundation. Mr. Brent will provide the patient perspective. The full bios for today's participants will be posted in about a week on our website, along with a recording of today's discussion. I now turn the presentation over to Genia Long.
Thanks for the kind introduction, Mike, and for the invitation to participate in this panel. Great. Before beginning, I'd also like to acknowledge my co-authors in this research. Together with Mike, they're Professor David Cutler of Harvard University, my colleague Noam Kurson of Analysis Group, and Bobby Dubois of the National Pharmaceutical Council. And for those who are listening, in addition to details that Mike just mentioned, let me just also mention that this research can be found in the American Journal of Managed Care. You see the citation here, including a technical appendix with more details for those who are interested in the methodology or any disease-specific details, which we're going to cover only very briefly on this call in favor of discussion of the payer management, patient access, and policy implications of the research. So as Mike mentioned today, we're going to focus on the example of gene therapy, which is, of course, as we kind of know here, not only coming, but here with U.S. approvals and many other therapies in development and on the way. The research that I'm going to summarize explores how cost shifting with the introduction of gene therapy or other breakthrough therapy advances over time, including both therapy intervention costs and other medical care costs, and whether, given the fragmentation that we see and know so well in the U.S. insurance system with patients switching coverage over time, whether that shift may create particular challenges to be addressed, and if so, what their nature is and what they look like. So specifically, we're going to explore the potential for disconnects between the situation of an initial payer assessing a new breakthrough therapy like a gene therapy and a downstream payer who is affected by that coverage decision. Now, that's always been the case to some degree for existing therapies with costs that can be more front-loaded and benefits that may be more back-loaded or extended over a long period of time in the context of patients that may switch insurance coverage before all of that stream of benefits, may be fully realized. So we explored whether and how, in the case of gene therapy, that dynamic may be particularly heightened. And as Mike noted, in that case, a single therapeutic intervention in a hospital or a clinical environment could result in a lifetime of avoided costs, and as well, of course, as life-transforming improvements in quality of life and productivity and other benefits for patients and their families. So some of the questions as these therapies come to market and are available to patients and clinicians are, will manufacturers, payers, and patients experience these, heightened version of these disconnects between essentially kind of who pays and who benefits from a payer point of view? Will that present challenges for patient access or for manufacturers who are developing such therapies or for payers who are confronting how to manage them? And will these challenges differ by disease and therapy type? And lastly, are there policy implications that we ought to be aware of or changes in how we do things that will be important to ensure that these therapies are available to patients who appropriately need them and for whom they should be available? So the research examined 5 different hypothetical therapies in order to explore these issues. There we go. A highly effective hepatitis C therapy, a curative gene therapy administered in childhood for beta thalassemia, a genetic blood disorder that affects the normal production of hemoglobin, and that's what we're going to focus on a little bit more today. A disease-modifying therapy for Alzheimer's, and a disease-modifying therapy for cardiovascular disease. These examples, which certainly are not by no means exhaustive of all of the potential breakthrough therapies in development, span different patient types, and that was intentional. So they may affect and be administered initially in children, adults, or seniors. They may affect different disease types and be affected or impact different disease-related burdens and experience different payer coverage patterns. Before moving on, let me just kind of emphasize that each of these therapies, from our point of view in the research, was hypothetical, whether they bear strong resemblance to actual therapies on the market or coming soon, because our aim was really to explore a range of situations in order to consider the economic incentives and challenges, the dynamics involved, and to identify where there might be similarities and differences among the examples, rather than to model very, specifically any particular disease or therapy with a high level of precision. Others, of course, will take that on in the context of a specific therapy and disease. Rather, our aim is to provide a useful framework and, in some sense, almost a test environment in which to think about some of these issues that may confront such diseases and new therapies. So as we noted, quickly kind of noting a couple of the features that characterize gene therapy from a payer sort of point of view, some or all of which, of course, may characterize other new breakthrough therapies. Gene therapy involves or might involve sort of a one-time, as we've discussed, sort of a one-time upfront administration of the therapy to a small patient population, defined by a particular genetic set of characteristics. Maybe small pediatric populations, moreover, in particular, as many genetic diseases may manifest in childhood. By definition, these breakthrough therapies, and gene therapy in particular, are kind of coming from a limited experience base, so there's potential for uncertainty over how enduring sort of the effects may be and what their profile over an extended period of time may be. The impact, again, as kind of noted here, on providers is also significant. Gene therapy is expected to be delivered in an inpatient hospital or an outpatient clinical setting, may involve medical procedures in combination with or preparatory to the delivery of the therapy, may be covered under the medical, of course, rather than the pharmacy benefit. All these sorts of characteristics suggest that the economics of impacts on providers may also be important to consider. And while this was not a major area of the research that we looked at, we certainly identified as something very important and something that our panel might want to comment on as we enter the discussion section. And again, this is certainly not a new or unique feature, but worth bearing in mind as we go through the examples. So let's start with a simple schematic of the situation that we have when we've got a new therapy that's going to replace a continuous ongoing treatment cost over a long period of time, potentially, as Mike noted, of lifelong duration, with a single large one-time treatment cost. So beta thalassemia would be an example of this, where children with beta thal otherwise would be treated with the current standard of care, which we assumed in the research to be a drug and the associated administration costs associated with infused chelation therapy, medical costs associated with transfusions, and so on. The current standard of care also has a cost, which you can see here in red. So the standard of care shows a chronic disease pattern of continuous medical costs over a long period of time, and under the new hypothetical therapy in blue here, with gene therapy being the example that we're discussing here, replace this by a one-time treatment cost, which may be high relative to any current single-period cost. So the new therapy reduces ongoing medical costs. In our hypothetical gene therapy example, they would be reduced from the red level on the slide down to a baseline level that otherwise average, healthy children would experience in blue in this case. So in the hypothetical example here, the net effect of the additional therapy intervention cost, again, is shown in blue. The net effect on other medical care costs is shown in red, and the difference between those, which is the net impact of the therapy overall, is shown in the green bar. So therapies may differ as to whether they're cost-effective or cost-reducing. In this case, overall, the therapy is not cost-reducing, but likely cost-effective. However, incorporating the effects of patients switching insurance coverage over their lives from one payer to another complicates our situation, and we'll talk about that. For the payer covering the one-time upfront hypothetical therapy, which would be payer A in this example, the blue bar increases, reflecting the idea that the therapy costs are going to increase, reflecting this upfront cost. The red bar, again, reflects the net impact on other medical costs, and the green bar, again, is the difference between the two. So not all of the red bar has been realized on payer A's watch, so to speak. So for payer A, the net impact on costs, or the green bar, moves upwards compared to the aggregate payer effect. For payer B, the downstream payer is in a very different situation. Payer B doesn't pay for any of the new one-time treatment costs and no longer needs to pay for the previous standard of care treatment. So for payer B, disease-specific drug therapy actually go down, so the blue bar is negative, and payer B also experiences reductions in other medical costs as a result of healthier patients. So it may also be the case that payer B experiences some more medical costs because patients live longer, which we'll call a mortality effect, the analysis that follows, and we also considered this effect in netting that out. So as our example here, payer B experiences net savings compared to the current standard of care, goes down, so the green bar is negative, below the line in this case. So let's move on to the more concrete examples in the actual analysis in the research. So let's see how that plays out. In particular, for beta thalassemia. So using the best available estimates in the published literature, which are all contained in the technical appendix for those of you who may be particularly interested, for costs, both at the standard of care and so on, for utilities and transitions, state transition rates. The hypothetical gene therapy for children with beta thalassemia was associated with a present discounted net cost versus the standard of care of just under $500,000. You can see that in column labeled A. So for purposes of this example, just for our information, we assumed a single upfront cost of a very round $1 million for purposes of exploration, that the therapy was administered at age 2, that it was 100% effective, and that patients would otherwise experience discounted lifetime standard of care therapy costs of about $500,000 from drug and administration costs associated with infused chelation therapy and medical costs associated with transfusions, discounted back to the present day at 3%. So with those kinds of very high-level assumptions, with a new therapy, patients avoid the excess medical costs related to that condition, so cardiac complications, for instance, for a net cost offset of about $378,000. Because patients live longer, they'll also have medical costs associated with those years of life at the level experienced by other healthy people their age, or an average discounted cost of $57,000 in this example. So the net result is a cumulative present discounted impact on healthcare costs of $179,000. So in other words, there is a net cost of the therapy much less than the $1 million upfront cost, and also less than the $500,000 discounted cost of the difference between the two therapies, the new therapy and the standard of care therapy. And that's due to these medical care offsets, as you might expect. So the hypothetical gene therapy in this case, of course, also has a very substantial impact on qualities, both because quality of life is improved for these children and because life is extended substantially. So at the assumptions reflected, that reflect an incremental cost per quality of about $8,500 for the intervention, assuming a value of a quality at about $100,000. So I just want to quickly note that looking across the examples, we're going to focus on gene therapy, but looking across them, we did find that for each, the new therapies were cost increasing but cost effective at a range of cost per quality thresholds. But our focus, as noted, really was on the difference between the upstream and downstream payers rather than the specific level of cost effectiveness for the new therapy. So let's turn to that. So looking at that question, what happens to the initial versus the downstream payer in terms of the net present value of these financial impacts? And here we're disaggregating the impacts on the initial and the downstream payer for this hypothetical gene therapy, and shows that the $179,000 aggregate net impact on healthcare costs that we just looked at is not what the initial payer experiences, and further that it matters who that initial insurer is, even when prices are the same, which is what we assumed. So when commercial payers are the initial insurers, that's the panel on the right, they pay slightly lower financial impacts relative to the aggregate healthcare costs, or $163,000, with the difference being additional downstream Medicare costs from children who now survive to age 65, thankfully. So the situation is different, though, for children initially covered by Medicaid, because they become covered by private insurance when they're older. We modeled that at age 21. So Medicaid pays all the treatment costs, and commercial insurers realize a benefit in the future with a net effect, more likely survival and lower per survivee costs. And we can see that for every patient whose treatment at age 2 is paid for by Medicaid, commercial insurers benefit by a net cumulative PDV of about $121,000, with Medicare experiencing a small loss due to the additional survival impact. I'm going to go quickly over the Alzheimer's example, because we're really focusing on the gene therapy example today. The point here really just being that slowing the progression of Alzheimer's reduces the likelihood of needing long-term care at any age, which reduces the long-term care costs both to families and to Medicaid, but it also increases the total burden on families to care for patients at home while they're less, but still impaired. And you can see that effect here. Okay. So just some quick takeaways, and then I'm going to turn it back to Mike and the panel for discussion. In each of the 5 hypothetical examples that we modeled, we saw gaps between the net impacts on the initial and the downstream payers. So we do think this is an important topic for continued investigation for folks to think about. Because patients switch coverage over their lifetimes, an individual payer making a coverage decision on one of these new therapies would not expect to experience the full set of downstream benefits. So while this phenomenon is not new, we're investigating this in the case of gene therapy because we expect this kind of disconnect to be exacerbated. But this is exactly the kind of clinical breakthrough that we want as a society. So in the extreme case, a single intervention that, as Mike noted, can restore a lifetime of health. So we'll be very interested in what the panelists kind of have to say about the challenges to realizing some of those benefits. As a last observation, there's been much conversation recently, and I'm sure the panel will talk about sort of the most appropriate and creative payment models for gene therapy and other similarly transformative therapies, given some of the characteristics that we identified earlier. And I think one of the things that the research suggests is that these examples are going to have to be kind of tailored to the situation, because we do see a range of models across the examples. So at that point, let me stop and thank you and turn it back to you, Mike, for the panel discussion.
Thank you, Genia. We now transition to our panel who will provide their perspectives on the challenges and potential solutions for these therapies. Dr. Michael Sherman will provide the commercial insurer perspective. Jeff Myers will present the managed Medicaid perspective, and Timothy Brent will provide the patient perspective. Dr. Michael Sherman will provide his thoughts first.
Well, thank you very much, and I thought that was a great framing of some of the issues and challenges. I come at this from a commercial health plan perspective, and I worry about balancing access and affordability. And what makes this particularly compelling is many of these treatments, and both some recent advances and some of what I see on the horizon, are life-changing. We need to figure out a way to pay for them without bankrupting the system. For many of these, they are clearly things that we want to make available to ourselves and our loved ones. So shame on us if we can't figure out how to balance the financing in a way that doesn't create restrictions. That says, as an insurer, when our costs go up, we need to raise the premiums that are felt by our customers, which are primarily employers, both large and small. If we had, at a point in time from now, let's say 5 years, $1 million therapies that impacted, let's just say, 0.1% of our membership, and we didn't have some innovative mechanism for paying over time, we'd have to charge each and every member, every man, woman, and child in our population, approximately $1,000 a year to cover that. And at that point, we would see a pretty big public backlash. So it's really important that we figure this out. Some of the challenges and questions that we think about, again, these are likely to have a high upfront cost, and in many cases, it's going to be justifiable. We've all dealt with and been concerned about costs that are completely out of whack. In these cases, it's likely that if you can do something that is life-changing for someone early in their life, particularly for thalassemia, sickle cell anemia, hemophilia, where there are large costs that go on for years, that these may be justifiable. But again, some of the questions, what is fair value? Why should they cost what they do, and how do you think about what is reasonable in terms of the capturing of value? I thought the beta thalassemia example was terrific, and that got us and I haven't independently reviewed them, but that would show, according to the analysis, cost of $8,500 per quality. Now that's terrific, but a lot of people worry, a lot of people worry that if you gross it up to $100,000, perhaps the manufacturers and the producers of the gene therapy would charge not $1 million, but $12 million. Now that's clearly ludicrous, but it really calls into question how many years is it fair, appropriate, ethical to take credit for? How much of that value should be captured by the pharmaceutical company? How much of it should be captured by society? And it's not a right or wrong, it's just something we need to think about as we seek to balance the cost and the access. It's also worth noting, and again, looking at the big picture, not just from the seat that I occupy, we want there to be innovations. We want capital to flow to companies that are doing innovative work so that we will see the next generation of advances. And given that the cost of capital for an early stage company doing this kind of research can be 30 to 50%, there also has to be a sufficient upside there to attract the capital and the research dollars in the first place. So those are all part of what makes this fairly complicated. In terms of solutions, again, as I said, we need to think about how do we come up with solutions so that the cost and concern about the value don't become barriers. And what really highlights this situation is the fact that we're talking about therapies that are likely to have a high upfront cost. If you look at Hep C, which had a fairly high upfront cost, particularly for something that can afflict 4 to 5 million Americans, but really, if you think about the long-term benefit, there's significant benefit. The concern on the part of health plans like mine was how do you absorb that upfront cost, which for many of us was over 2% of our spend. And if you're a not-for-profit health plan, which is trying to achieve a margin of 1 to 2%, and you have a surprise which is more than 2%, you've got a problem. And we, like others, had a problem with Hep C. So looking at therapies which are likely to be even more expensive has everyone watching this very carefully. If you think about it, some of what we're trying to achieve are balancing the cost and the benefit. So the question to me becomes, both to achieve that balance and to drive affordability, how can we come up with a mechanism to pay for treatments that may be one time, but that give a benefit over many years? That not only helps with the affordability, but it also helps with where there may be differences of opinion over how long the therapy is likely to be durable. Telling a manufacturer, come back when you have 10 years of data where there's a genuine unmet need does not seem ethical. Yet, for the pharma company to capture reasonable value, there needs to be a way to overcome differences of opinion. So continuing to pay up to a set point so long as there is continued durability and demonstration of the results seems like a good way to go. Now, this is hard, particularly in our society where we don't have a single payer. So if you want there to be a payment over time in a multi-payer system, you need some sort of portability. And again, our system wasn't built for that. It wasn't built for these kind of therapies. So in terms of potential solutions, one, we might see collaboration among the payers. That could either be semi-formal through some sort of large mechanism and common policies, and you would need a common policy to have portability. We'd have to agree on who should receive a treatment and who should not. And I'll point out that doing that in a vacuum might create legal concerns about collusion. So it would have to be done with appropriate legal safeguards and legal counsel, et cetera, in a way that was transparent and clearly seen as promoting access rather than colluding. That's possible, but again, complicated and hard to get everyone on the same page. I'm also thinking that before that, we might actually see a voluntary approach where a subset of payers get together and agree to essentially allow portability among themselves. And essentially, the way I see it, the cost of entry would be to agree that you would need to agree to accept that same liability from others. In other words, if you want to export a patient with a certain ongoing liability for, let's say, gene therapy, you need to agree to import similar types of patients who've received the same treatment. So you might see some pressure among other payers who aren't part of that to be a part of that so that they're not disadvantaged upfront from the cost process. So that sort of thing might occur organically, and some of us have already started to try to promote dialogues. Another approach might be a third-party entity coming together, and again, there's been some discussion among various parties of an entity that might accept a certain amount of money. It could be a PMPM, it could be payment over time from a health plan, would take the patient and the liability, and then would manage that liability ongoing no matter where the patient goes downstream. Again, some challenges there, particularly in the early stages when there's a small population because of the actuarial risk. In addition, if that entity were to be regulated as an insurer, they would need deep reserves, which means they would likely need a partnership with a larger insurer or other type of organization to help meet those regulatory requirements. But that is another potential solution. We could also see a public fund type of approach, a carve-out where essentially a certain amount of money is taken out of the premium and put into this public fund, and that fund then pays for all of the care involved with the gene therapies and also gets around the portability issue. My problem with that, I think that's potentially doable. The problem with that is that you then have, in theory, a third party, perhaps a political entity making decisions over what is covered and what isn't as part of that public fund. And I worry about public pressure to approve things because of unmet need and what are admittedly some sad stories rather than based on the objective evidence. So a lot of challenges here. I'd also note that we need to seek waivers from the Medicaid best pricing requirements. So if we're paying for a gene therapy over 5 years, let's say $2 million, $400,000 a year, and we stop paying after 2 years because it stops working, that would be a 60% discount, which might create a problem if that is viewed as being the best price, even if it is only for a small percentage of patients who do not show durability. So that's part of what we need to figure out and work with the government and different regulators and HHS, CMS, et cetera, to solve. One final comment. These, again, are things that are likely to be life-changing. These are therapies that we want to make available. So if we can't figure out, payers, providers, pharma company, et cetera, how to work together to drive access, we're likely to see regulations and other types of activities which do not promote fair and appropriate access among stakeholders. So I hope this is a wake-up call to work together and to figure it out ourselves. I'll turn it over to Jeff Myers now. Jeff?
Well, thank you, Dr. Sherman. I'd like to springboard off some of Dr. Sherman's comments because I think from my perspective for the Trade Association for Managed Medicaid Plans, this research really does raise some fundamental issues on how the program is growing, who it covers, and how, given that the Medicaid population is generally sicker than the commercial or Medicare population, its growth as a result of the ACA now means that it covers more than 22% of the U.S. population, and 75% of the Medicaid population is now covered by full risk managed care plans, which means they're taking a full risk in the space without really the ability to do a change of benefits or other types of items that you see in the commercial space. So this research, I think, drives a couple of key questions for us to consider. The first, as Dr. Sherman raised at the end of his comments, was what does it really mean for the Medicaid drug rebate program that was put in place in 1990 before there was the concept of a $1 million drug? I think the experience of our plans around the Hep C release of Sovaldi and Harvoni clearly indicate there is a massive problem when the pricing model is built on capturing all of the future value in a very large population. But even if you're capturing the majority of future value in a small population, the opportunity to really disrupt the system because of the overall expense is pretty great. So one of the things that society is going to have to really think through when it comes to the treatment of the most disadvantaged in America is how much money is available and for how long should that money be available for treatments that have durability over several years. As Dr. Sherman mentioned, obviously in the MDRP, having a product come off use or become less effective after several years would have a devastating impact on that company's ability to price for their drug as the way the MDRP is built today. And I think from our perspective, one of the key messages, key takeaways that folks looking at this research should consider is that the design for drug pricing, which is influenced dramatically because of the size of Medicaid and the use of the MDRP, suggests to us very strongly that the MDRP should be reconsidered because it has an outside influence not just on Medicaid, but ultimately on the commercial and Medicare markets as well. The second item that it raises about who gets the value and who pays is directly applicable to Medicaid because of the churn rate. What we know in Medicaid is that the churn rate is quite high. I have a number of plans who have populations in excess of 20% with no fixed address that see churn rate that looks more like about 8 months if you look at health affairs. What we also know is that very sick Medicaid recipients tend to stay on the full risk plans that they are on where they are receiving benefit. So essentially you have a risk selection problem where the plans would have to pay an extraordinary amount of money for new therapies and possibly never see a real return, even if the return is available to the state but not the plan itself. Again, going back to the argument that some of the innovators in the Hep C space made about the cost of their medication is that society would ultimately see a dramatic savings because of the reduction in liver transplants and other items. While that hasn't actually been true as of yet, if you look at the UNOS data, there are actually still more liver transplants than there were when the drugs came out. That may well be true over time, but it most certainly will not be true for the plans that had to pay for the cost of that drug, knowing that the rebates flow to the state and not the plans under the ACA. So thinking through how states can build a reserve fund or some other financial pool that pays for this new innovation is terribly important, because from the plan's perspective, this innovation is truly important. New treatments that may lessen the need for extensive costs over time is incredibly valuable. So it really comes down to what are the economics and what are the ethical responsibility of the manufacturer and discoverers to receive a fair return on investment for the enormous amount of work they've done on those products, while still not creating a problem for a program that serves the poorest Americans, I think, is a real key. And then I'd end with this. Thinking about where we're going to go with genetic therapy or other items that have durability over time makes me wonder how we can fully integrate the benefit in a way that truly addresses some of the cost issues that Medicaid has. There will be some drugs that are produced that really don't have an economic return. In other words, it is a great product for those in need. It should be ethically given, but it may not actually result in lower spending either when it's administered or some years in the future. How is society going to manage that, given that Medicaid's growing at a rate which is unsustainable for the states, and in less than 6 years will be a $1 trillion program? I think the Wall Street Journal had a great article yesterday about the impact Medicaid is having on those state budgets, and the kind of research that we saw today that shows how states should start considering high-cost drugs and the variety of options they have to them for this population is really important. Ultimately, though, it really is about, from our perspective, the beneficiary and enrollee, and that's why I'm delighted to turn it over to Tim to talk about it from a beneficiary point of view. Tim?
Thanks, Jeff. Yeah, with the gene therapy, there are challenges that are facing the patients, and it really depends, in my mind, and a lot of things that we've read and that's been published as to the history of those particular communities, of those with the chronic disease and their families. For instance, with the bleeding disorders community, things have changed a lot since the 1960s when boys with hemophilia only lived to be about 20. Now we're at a point where the life expectancy is just 10 years below the national average of those unaffected. There have been challenges, though, as it relates to some of the therapies, because like in the 70s and 80s, the contaminated blood infected about 90% of Americans with hemophilia, and about half of those died. So my point in saying these things is, with this history, is one aspect, too, to kind of think about is the acceptance of these therapies, gene therapies included. The patients, they're going to be asking themselves and asking others, is this gene therapy right for me? Is this a one-shot deal, if you will, with no future options? I would say many individuals with a chronic disease and their families, know the opportunity of gene therapy and are cautiously optimistic. So with the patients and families, they'll want to know if there's any long-term negative effects in taking the therapy. Would it affect the immune system, for example? Would the effect be only with the individual who receives it? Or is it going to be, is there something about their children, the individual might have, what are the down the road effects, and will there be degradation with the efficacy of that gene therapy over time? Of course, these things we don't know now. We won't know initially, or maybe for a long time. So those are things that I think not just the bleeding disorders community, but others with a chronic disease who currently have a therapy that is life-sustaining, unlike some other chronic diseases or diseases where the child has a very short period of time to survive. So with that being said, too, the other challenge I think is with the individual, with the affordability for their portion of the expense of this. One of the things that I've seen, the Kaiser Family Foundation and the Health Research and Educational Trust comes out every year with a employer health benefits survey, and the amount of premium that's being paid by employees has been increasing year over year. Just so you all know, about 18% of the workers, on average, covered workers contribute about 18% of the premium for single coverage and 31% of the premium for family coverage. What's important to note, though, is of the 140 million people reported that were employed through the U.S. Department of Labor, 35% of those make $24,000 a year or less. So with the bleeding disorders community, even getting their life-sustaining factor concentrate can be a real challenge at times. Some of the approaches that we look at that may help in addressing some of these challenges. One, for like acceptance of the therapy, it can be as simple as engaging with the patient advocacy groups in general. Being able to get that education out there when it's requested by those community members, and especially in the sense of being able to create an effective bridge to have a productive dialogue early on. And these relationships can really, span several decades going forward. You're not going to just get anecdotal feedback, but what we're kind of looking at NHF is more through studies conducted through like ourselves and other organizations, that we can actually bring information together about patient-reported outcomes. What are the families dealing with? One of the things that we're doing now is rapid research cycles and beginning a longitudinal study through a registry through our own researchers. And I think that's really important because of the fact that even in the study itself, what I really appreciated was the fact that there was a discussion of the limitations of that particular report as it pertained to some of the cost offsets. Because if there's more, I would encourage the authors to maybe look further down the road in working with organizations to collect data, because especially with hemophilia, the offsets could be a lot larger than maybe what would be realized initially. And then dealing with the financial challenge, I think having realistic financing mechanisms are critical, which I'm part of that choir with Dr. Sherman definitely as well. I believe also one of the biggest gene therapy related risk facing patients is that the current system will fail them by not having the right financing mechanism. And that's really a tough place to be in, because really what we need is a more clearly defined and realistic financing mechanism. And this means something workable for everyone down the line. The pharmaceutical manufacturers, we want them to continue to be creative and create these therapies. Providers, hospitals, clinics, and pharmacies, we need them to be able to treat the patients. Even now with some diseases like polio, it is very difficult to even find the provider. So we have to, and with benign hematology for bleeding disorders, we are running in a shortage of clinicians, physicians especially. But then also the payers and then the consumers and families. We got to make it realistic for everybody to be able to work within this, and the system that we have now does not work the way it needs to, especially for gene therapies coming down the road. Mike, I'll give it back to you.
Thank you, Tim. We're now entering the Q&A portion of today's webinar. So first off, Michael, are there segments of the market that are more vulnerable to financial risk and uncertainty associated with gene therapies?
Yes. So, I think the the biggest challenges are we fall into two very different buckets. One are smaller payers that incur higher actuarial risk. There may be a gene therapy that we as a million-member plan, we're actually at $1.25 million. I think we're going to get 3 or 4 people. If you're $100,000, $200,000, you may get 0, you may get 1 or 2, and those can have very different implications for your financials. Second point I would make in terms of risk would be fully versus self-insured. There's a lot of question out there, much of it not yet answered, about differences in terms of how they may prefer to pay for these. In theory, a self-insured employer would care about matching the costs and benefits just as we would. In practice, they buy reinsurance, they buy stop-loss coverage at a certain point, and they may assume that they're better off than paying it all up front and having the reinsurer take over. The problem with that is that the reinsurers watch this as closely as we do, and they are likely, and they're already discussing, either raising what they charge for their services or having a higher cut point, a higher point at which the reinsurance kicks in, which could even be specific to gene therapy. That's going to create some barriers as well. I also think that there will be additional risk in cases where the data is questionable. It's easier in a sense, and again, I think of Retigene for inherited retinal defect, et cetera. So the data is very compelling, and a lot of the other data that I'm seeing early stage for many treatments is similarly compelling. So in that case, payers in general, I believe, will look at it and say, we need to find a way to cover it. If the data is dubious, kind of more in the middle, and the costs are high, you may see variability among payers' policies. Some may choose to cover it and others won't. The problem with that for this high a cost is if other payers don't cover it, the payers that want to cover it will be worried about what they call adverse selection, which would be, if we're the only ones that cover the gene therapy for hemophilia, do we really want all the hemophiliacs to join our health plan? And the answer is you probably want to spread them around the entire population. So again, a lot of unknowns and challenges may impact different segments, but again, solving that is going to be part of the challenge and opportunity.
Thank you, Michael. Jeff, what do you consider to be the biggest single risk to managed Medicaid plans resulting from gene therapy?
Well, I think the risks are twofold. The first is when the gene therapy becomes available. We assume the gene therapy that becomes available has really good data and is clearly a class differentiator. When that product becomes available commercially means a great deal, because if it happens in the middle of a planned contract year, the plan hasn't had an opportunity to build that cost in for actuarial soundness reasons with the state. I think a lot of what you saw in the Hep C case was exactly this problem, where the impact of cost around treatment for Hep C caught many of the plans flat-footed, and for several years the states had not trued up with the plans in terms of the tens of millions of dollars they had paid for Hep C treatment. So I think one is a timing issue. The second is a bigger issue about where the states would like to take their Medicaid programs, because ultimately as these products make their way through the pipeline, the plans will sit with the states to start to build actuarial models on the cost and get some idea from the states about how they wish to build it in an actuarially sound fashion, which many of you may know is a requirement for the use of managed care in the Medicaid program. This is going to put the states in a very difficult spot, knowing that the program is already growing at a pretty good clip, about 6%, and gene therapy that has more than just a couple of people in the population is likely to drive cost significantly. But that's the discussion that society needs to have. How much investment do we want to make in this space? What is the appropriate way to invest? And how can we do it in a manner that is sustainable over time, which has to do with both the pricing model that the pharma companies will use and with society's need to balance money going into the Medicaid program with other priorities. but ultimately that long-term risk that the plans face is about how the payment actually gets made. Is it going to be made over time? Is one plan going to be stuck with all of the risk, or are states going to make decisions to carve out these very expensive drugs so that they don't destabilize a given plan in a particular year if they get, say, 2 or 3 recipients of million-dollar therapy? That's what we're seeing in the short term, and I think the longer-term issue really comes down to how the states are going to manage it.
Thank you, Jeff. Tim, what is the biggest gene therapy-related risk facing patients?
Well, you know, I think I'm going to stick with the financing aspect of it. You know, the risk is the failure of the system. You know, we're at a point right now where I think that, you know, we can really make some headway and create something a bit new. You know, receiving full payment up front to pay for the therapies, you know, they may no longer, especially the gene therapy, may no longer be the norm for the manufacturers in general, and that's not necessarily a bad thing, because as long as the revenue stream begins to flow, and of course we have to think of the critical clinical benchmarks reached for the recipients of the therapy, the gene therapy can be much more widely accepted. And, you know, one of the opportunities in this, you know, kind of turning that risk into an opportunity is, you know, the new financing models that would be created that are accepted potentially along with the therapies could even help reduce health disparities that currently exist too. So that's probably one of the main risks, I think, but also it can be an opportunity.
Thank you, Tim. Michael, in thinking about the various financing solutions out there, do you think that there will be a single approach to paying for gene therapies, or do you think that these solutions will need to be tailored to either the disease or the population?
You know, I think there are going to be different approaches, and I think so for a couple of reasons. And think about how we might segment the different therapies. For example, again, the first gene therapy we saw, Veretagene, is for blindness. There's not a lot of cost offsets downstream that occur to an insurer. There are some that would incur to caregivers and others, if you think about the whole social support system, but those don't actually create premium or cost offsets for an insurer. So those might be a different issue than something like, again, a hemophilia or a beta thal gene therapy, where there are downstream cost offsets that one could align with. There's also differences between therapies that are given in early childhood versus later in life, and we have to think about how do we value these appropriately, again, given the long time periods and et cetera. And again, part of what goes into that are differences in how patients are managed within Medicaid, commercial, and Medicare, and thinking about some of the transitions there. So there's a lot of moving parts, but ultimately I think that we are going to treat some of these differently.
Thank you, Michael. Jeff, what do you consider to be the biggest roadblocks to value-based contracting for gene therapies?
Well, I think the first and foremost is the antiquated way the Medicaid drug rebate program works. Probably you could make an argument whether when it was introduced in 1990 that was necessarily the best way to do it, but it would certainly be very hard today to say the MDRP as it's done today matches the way Medicaid is today, where it covers a large portion of the American population, and a large portion of that population is in managed care. Just to put it into perspective, in 1990, only 1 in 11 Americans was enrolled in Medicaid, and less than 8% were in full risk managed care. Now you're in excess of 22% of all Americans, well over 1 in 5, and 75% of them are in managed care. So the design of the MDRP, I think, limits the ability to do value-based and risk-based contracting. I think the second item is the way in which Medicaid is funded at the state level and the way the state and federal match works. Many of you may know that the match rate for many of the populations in Medicaid is higher than 50%. So the cost of the drugs, even though the rebate flows to the state, is generally borne by the federal government. And that's going to be, I think, an issue as these expensive drugs, particularly ones that have the real probability of being able to treat things like Alzheimer's, which has a large Medicaid population, is likely to have impact. So I think until you really address the MDRP piece and then you start thinking about the overall way in which Medicaid is financed, it becomes very hard for me to think through innovative policies for funding for therapeutic products in the gene space that are likely to be 7 figures or more that have activity over several years.
Thank you, Jeff. I'd like to thank everybody for submitting their questions. Unfortunately, time permits us from answering every question. I'd like to briefly summarize some of the main points from today's discussion. First, transformative therapies will change the way that we both deliver and pay for care. 2, these impacts of these therapies will vary across diseases and populations. 3, payment mechanisms not only need to address the short-term financial burden, but also address uncertainty around efficacy and duration of efficacy for these therapies. 4, we heard there's a need to update the Medicaid drug rebate program to handle these new therapies. 5, we heard that, the short-term financial burden is not only an issue for payers, but it's also a key consideration for patients. 6, we heard that, the financial risk placed by these therapies is actually asymmetric, where smaller plans will be at greater risk. There are a lot of issues associated with those being fully insured versus those being self-insured and how they deal with that, especially around the issue of reinsurance, which is something that doesn't get enough attention yet. And then finally, there was a concern around adverse selection. If there's non-uniform coverage around these therapies, that creates problems, as patients who need the therapy will obviously migrate to those plans that provide coverage. I would like to thank today's webinar participants for sharing both their time and thoughts with us. Thanks, and have a great day.